Hello and welcome to the Motivational Midwife. My name's Lynn Jones, and as a result of another email, I've been asked to do a planning video for NMC OSCE, and so that's what we will do today. So the planning station then. So it's the second station of your API. It's a 14-minute station and it is a written station. So you need to make sure that you do write legibly, and I will go through some of the things you have to take into account while you're going through this station. So I've used the scenario that the NMC use in their mock midwifery literature. So you've got a para 1 who's 38 weeks pregnant, coming in with a fresh PV loss and some abdominal pain, and she looks in pain when she arrives. So you've already been given this scenario and you've done your assessment station already. So looking at the market criteria, obviously you've got to assess the current situation. So what has she come in with? What is the issue? And in the assessment station, you will have investigated that in a little bit more depth. Looking at her relevant medical history, her obstetric history, medication and her allergy. So this is our SOMAD acronym that we can use. Looking at the assessment findings. So what were the findings of what you did on the assessment station? And then come up with a diagnosis based on those findings. And then you're looking for what is your plan of care? So what are her issues and needs? Setting an appropriate review time for the doctors to come and see her, and that will be in line with whatever her Meows score was on the Meows chart. And if you turn the Meows chart over, you've got some guidance on the back of that Meows chart to actually help you in setting an appropriate time review. And then we need to make sure that what you're suggesting is actually evidence-based and in line with national guidance. That you use appropriate professional terminology. So try and avoid, although I've got some abbreviations in this presentation, it's mainly because of the lack of space on the screen to actually write things out in full. But ideally write things in full rather than abbreviating them. That you write clearly and legibly. If the assessor cannot read your writing, then you're not going to pass that station. And make sure that you print and sign and date it. Often there is a space already on there for it, but if not, just print and sign and date it anyway. Okay, so our situation is we've got a 38-week lady, and her name is Amy Hall. So you would also put those details at the top of your planning paper. So you've got they may already be pre-populated with her name, her date of birth, and her hospital number. That may already be on the sheet that you're due to write on. If it's not, make sure that you have those details on there. As a minimum, her name, her date of birth, and plus or minus her hospital number. Your situation then is that she's a 38-week para 1 who's coming with abdominal pain and fresh PV blood loss. So what's our background? So looking at, and you're given this information. Okay, you've been given this information on your assessment station, so you've got this information already. So she had sexual intercourse at 7:30 this morning, and she's had intermittent abdominal pain since about 8:30. And then about 9:30, she noticed some small red fresh blood loss when she was wiping and some staining on her underwear. Okay, so we're keeping that SOMAD, so our social history, obstetric history, medical history, allergies and drugs, in that sort of logical format. So you can put the information that you've been given in that format. So if I just show you, so this is what you'll be given. Okay, so you've got all her history there. It's not necessarily in that SOMAD order, but you will be given that. Okay, so all I've done with that information that I was given is put it into a SOMAD order so that I know I haven't forgotten anything. So she's married and lives with her husband and child. She's an ex-smoker. That's her social history. So her obstetric history, she had a normal vaginal delivery and an uneventful pregnancy at 40 weeks in 2015 with her first child. And this pregnancy, she's under consultant care because this is an IVF pregnancy. She had a low-lying placenta at the 20-week scan, but at the 34-week scan, it was clear of the os and there was normal growth, and she was referred back to midwifery care. She's rhesus negative, and she did have anti-D prophylactically at 28 weeks. So her medical background is that she had postnatal depression following the last child, which was treated with counselling and no medication, and unexplained infertility after the last child. So this pregnancy is an IVF pregnancy. And her allergy and drugs, she's allergic to codeine phosphate, which gives her severe nausea and vomiting, and she's on ferrous sulfate, 200 milligrams twice a day. So there's my background. It's all there, and this is what you're going to put on your paper. And if you keep it in that nice logical order, then you're not going to miss anything out. So the assessment, and I would, on your piece of paper, I would actually put it under heading. So I would put situation, write my situation, background, write my background, assessment, write my assessment findings. And these are your assessment findings from your assessment station. And again, you'll be given those findings for your planning station. They will give you what those findings were. Okay, so initially, in this particular scenario, she'd already, your scenario stated right at the beginning that she'd already had urinalysis and a CTG carried out, but they were still done. So you're going to count them in this assessment bit. So urinalysis and the results are there. Her maternal observations with the results there. Her AVPU, so she is alert, fit and well, because remember these are all relating to your meows chart, and her pain score. So 2 out of 3, she has got quite a lot of pain, hasn't she? So she's on the meow score, she's going to score for pain, but all the rest of her observations are actually within normal limits, and she's not going to score anything for those, but she will score for pain. And then don't forget your physical abdominal examination and your fetal well-being examination. Okay, so you'll have done your findings from your abdominal examination and your findings from your auscultation with your pinard, and then the CTG that was performed as well, the findings from that, which in this case were reassuring. So on the basis of that, your diagnosis is that it could be a postcoital bleed, or it could be your differential diagnosis is it could be early labour and a show. So then what's your recommendations? So I would say, even though this is not specifically in your marking criteria, it's always good practice to discuss all the options with the mother. So document that you're going to discuss the options with her, that you're going to get the doctor to review within, and at this point you're going to need to write what the appropriate time frame is. So if your meows says the doctor needs to review within 30 minutes, then you need to put in there doctor to review within 30 minutes. Also, if your observations are needing repeating within a specific time frame, that's a good place to put that in there. So repeat meows obs every 15 minutes, every 30 minutes, every hour, every 4 hours, whichever your meow score comes up. For this particular one, I would say that it's not going to you're going to ask her about her pain, but I mean the rest of her observations were within normal limits. Monitor her contractions for length, strength and frequency. Send some bloods. Now, depending on your scenario, will depend what bloods you send. So if you're thinking urinary tract infection, you will also send LFTs, Usenis, and also a CRP on top of these other bloods as well. Now, remember, she's rhesus negative, so hence we do need to think about a Kleihauer blood test there, because it may be, if she doesn't go into labour, then she's going to need potentially some more anti-D, because she is only 38 weeks. So although she's got a few contractions and tightenings at the moment, it could all fizzle out and she may not go into labour for a little while longer. So we need to make sure she doesn't need any extra anti-D. She did have some blood and some leukocytes, but you're going to get a repeat MSU from her and send it off for microscopy, culture and sensitivity. Consider another CTG, so you're or certainly monitoring the fetal well-being. So it may be that you're intermittently auscultating, or it may be that you're going to do another CTG before she goes wherever she's going. Think about whether or not she needs to be admitted as well. So I haven't specifically put admit to on here, but depending on your scenario, it might be appropriate to admit to a delivery suite area, or it may be appropriate to admit to the birth unit or a triage area. It just depends on your scenario, but that needs to be within your plan as well if she needs admitting. A speculum examination. Remember, she had a low-lying placenta at 20 weeks, and although it was deemed to be 2 centimetres clear of the os at the 34-week scan, you know, it's possible that that may not be particularly accurate. So therefore, a speculum examination to just see if you can see if there was any obvious reasons for that PV loss. And while you're there, take a high vaginal swab to rule out any infection as well. And obviously her pain score was quite high, so you need to consider analgesia in your plan. And as I say, this is for an antenatal, and most of this plan has been tailored towards that specific scenario that we had here. But again, depending on your scenario will depend on what your plan will be. So if you've got somebody with an infection that's going to need some antibiotics, they may choose to keep her in overnight and monitor her, particularly if you've got a preterm antenatal. If it's a labour scenario, and you've got someone that's coming in labour, then your recommendations will, planning recommendations will be very much around labour care. So if it's a low risk pregnancy, what would your care be in labour? So how frequently would you be monitoring the contractions, thinking about bladder care, doing her observations, offering vaginal examinations, listening to the fetal heart. Is that, you know, is it, depending on the individual situation, intermittent auscultation, how frequently are you going to be doing that, or CTG? You know, have to base it on the scenario and what it is evidence-based for that particular scenario. And if it's a postnatal scenario that you have, again, similarly to this one, you know, how frequently does she need her observations doing? How quickly does she need to be reviewed, depending on the meow score? Does she need bloods taken? If so, which ones? Does she need the urine sample sent? If so, send it. Is there any other things that might need doing? So perhaps swabs from a wound, if you're thinking sort of wound infection. Does she need analgesia? I mean, that's particularly relevant for probably all three possible scenarios that you will get. So key points. So watch your time. 14 minutes goes very, very quickly. Stay systematic in your approach. Make sure that your writing is legible, that your assessor is going to be able to read it. Use your professional terminology. Avoid abbreviations, and remember to sign it. Print your name, sign your name, and date it. And good luck. And there you have it, NMC OSCE Station for Planning. I hope you found that useful. If you haven't subscribed to the channel already, please do so. And you can also find us on Facebook. And I look forward to seeing you next time.